Hi, everyone. I'd like to invite Mauricio to come up and make an introduction.
Thank you so much, Sheila. I hope that the conversations on the tables were very fruitful. I'm looking forward to see all the comments. So it is my great pleasure to introduce you Dr. Daniel Vigo. Dr. Daniel Vigo is a psychiatrist, clinical psychologist, and public health specialist, originally from Argentina. We have been speaking in Spanish on the side, which is very refreshing for me. He is currently an assistant professor at UBC, a lecturer at Harvard Medical School, an advisor to PAHO, the Public Agency of Health, and the WHO, as well as the chair of the Services and Policy Work Group for the WHO World Mental Health Surveys Initiative. And one of the things, if I keep reading your CV, oh wow, I see in here in front of me a list of a significant amount of achievements. No surprising, Dr. Vigo has been recently nominated, recently appointed, is the right word, by the Premier of BC as the BC Chief's Scientific Advisor for Psychiatry, Toxic Drugs, and Concurrent Disorders. And something that really caught my attention in the title of that appointment is the Concurrent Disorders, because it's exactly the place where all this work lives, that intersection with brain injury being part of that concurrent disorder. So it's my great pleasure that Dr. Vigo was able to join us last night and today, and please help me to welcome him with a round of applause.
Thanks, everyone, for inviting me. Thanks, Janelle, Mauricio, and everyone here for such a compelling, effective, and moving case for prioritizing brain injury in the context of the different problems and disorders that may affect our daily life. I want to highlight that the title there doesn't fully do justice to how much the brain injury piece is a key component of my appointment. Thank you. Sorry about that. If you look at the video, which is available on the website of my lab, the Mental Health Systems and Services Lab at UBC, you will see how much the Premier and the Minister of Mental Health and Addiction have come to realize that without putting an emphasis on acquired brain injury as a component of this new clinical triad that we have now as one of the most prevalent forms in which the people with concurrent disorders present, without having emphasis on that, we will not be able to serve these people adequately. And so during the process that led to my appointment, the idea was, okay, so what can we do that has never been done? And the main thing was that there had never been a system-wide centralized approach to collating data, analyzing data, and making recommendations. So that's what my appointment basically does. It mandates my office to look across the system, all health authorities, all ministries, all publicly funded programs, and make the right questions to understand the continuum of care for these patients, and how can we improve the existing available services. And my mandate is, again, to provide ongoing recommendations to the Premier and the ministers in order to improve as the evidence allows us to come up with guidance that we can feel confident about. And the two key population areas that I'm focused on are, again, taking a life course perspective. On one end, folks that already have the mental illness, the substance use disorder, and the acquired brain injury, which, as the minister said, has shot up exponentially because of the availability, the widespread availability in the market of toxic drugs. But there's also, and so those folks with that clinical triad need a type of services that simply doesn't exist. It doesn't exist in the sense that our community-based care is not sufficiently intensive and able to cater for those needs, and our housing approaches are still there's still a long way to go for us to reach that level of complexity and our ability to stratify the needs adequately. But we're going to get there. But as importantly, there are people in a community, young people, kids, who may have some of those components, severe mental disorders, sometimes substance use disorders, but haven't yet developed the acquired brain injury due to either traumatic brain injury or acquired brain injury due to anoxic brain injury secondary to overdose. We know very well that overdose produces brain injury. We know that if it's severe enough to show up as a clinical diagnosis in administrative record, that person has a 50% chance of dying in that same episode of care, and a 30% chance of dying shortly after, in a few years. And so imagine the ones that are not detected in the clinical records, in the administrative data at that point. There's a continuum of acquired brain injury that coexists with the mental illness and with the substance use disorders that, again, makes it very, very difficult to engage the patients in care and to provide the level of complexity that they need. So this meeting, this encounter has been enormously informative for me and enlightening, in the sense of what are the priorities, what are the families saying that these people need, what are the people themselves saying that they need. And I remember one particularly good summary that I heard yesterday as a question that one of you put to the panel, which was, so what's the equivalent of a helmet for the toxic crisis and the anoxic brain injury? And I think that's a fundamental question, because several interventions, public health level interventions, the helmet, the safety belt, are mandated, and they're mandated for a good reason. So I was thinking about what can we consider could be a parallel to the acquired brain injury epidemic that we have, and there are some clear interventions, including the opioid agonist therapy, the naloxone kits, the safe consumption sites, et cetera, but we have to understand how much of those are needed, because at this point there isn't a centralized way of calculating that, estimating that, costing it, and rolling it out in a cost-beneficial basis. So in any case, I will stay in contact with all of you to inform my advice to the Premier and to the ministers, and I hope that I can come back to you, either in a meeting such as this or individually, with some good news about how we can improve the system of care. So that's it on my end. I'm going to let you go to your lunch and continue with this great work that you do. So thank you so much.
Right now, if I could invite Dr. Julia up to the stage, and also Jacob. I'll let you introduce, and then we'll do what we need to do.
Okay, great. Hi, everyone. I'm Julia. Everyone on Zoom, hello to you too. I'm going to introduce Jacob, who I've known for a few years now. Dr. Jacob Stubbs did his PhD in experimental medicine at the University of British Columbia. He uses quantitative brain imaging to look at traumatic brain injury and stroke, with a focus on homelessness and precariously housed people. So very relevant to this topic. And in 2022, he served as a visiting scholar at the Harvard Medical School, and he is now in med school at UBC. So that's his bio. I'm going to tell you a little bit extra as well, and some translation. It says he did his PhD, and he's now doing med school. So by the end of this, he'll be doctor. And in his PhD, he won prestigious awards that, for most of us, we don't even try because it's just not going to happen. He won Vanier and Killam, so those researchers, yep, you can close your jaw. And he was the first, what's really notable and important for today, he was the first to lead a meta-analysis and systematic review to put some numbers to what we already know, and that is people who are in precariously housed positions have brain injuries. So that is what he's going to be talking about today. Thanks, Jacob.
Jacob and I are going to do a little technology switcheroo because we love technology today. Before that, I'll just invite you as well to access the question and answer session on Mentimeter for Jacob's talk. So again, as with this morning, if something comes up while you're listening to him, put it into the Menti for a question, and you can also vote on those to get the questions you most want answered. So bear with us. We're going to just do a quick swap and we'll be ready to go.
All right, easy as that. Well, thanks very much. Julia gave away the crux of my whole entire talk, so I'm going to tell you what you guys already know for the next 30, 40 minutes or so. But I'm really, truly excited to be here today. This last night and the discussions today have made me feel more positive about the research that we do and the direction that we are going. Am I speaking too loud or too quiet? All right. How's this? I'm usually a yeller, so I try to stand back from the microphone. But yeah, my name's Jake. I did a PhD with a study at the University of British Columbia, and I'm just going to give you an overview of some of the work that we've done in the last few years that looks at the intersection of brain injury and housing instability. I'm not far enough along in my career to have any major disclosures. We're very thankful to our funders who have funded this study. So I'm going to start off with a little exercise. Do we have any neuroradiologists in the room? Physician trained, fellowship trained, looking at brain scans? Good. This whole exercise was key to having none of those in the room. So I'm going to give you 2 brain scans, and I'd like you to just simply think how old each person is, okay? So I'll let you look at those for a second. Those are 2 different people. I'll walk you through, as also not a neuroradiologist, what I see just in about 20 seconds. So on the left-hand side is a relatively normal-looking brain. It's fulsome. This is a slice through the very front, like this. On the right-hand side, the gyri, so the folds of the brain, are a little bit shrunken. The ventricles in the middle, which are the fluid-filled areas of the brain, are expanded. And all of this is suggesting that this person has a lot of just general brain atrophy. And so from an outside perspective, if you're looking at these 2 people, I would guess person on the right is 40, person on the right is 85, 90 maybe. It's normal that your brain shrinks with age. In actual fact, the person on the left is a control participant from the general population, and the person on the right is one of our hotel study participants who has a history of homelessness, substance use, and traumatic brain injury. But the key to this is that they're both 55 years old. So I'm up here today, but I am a behind-the-scenes guy. I stay out of the limelight. I'm a physician scientist in training, but I'm like a data guy. So my role here today is to walk you through the research on TBI and housing instability, so that you, experts in advocacy, experts in the legislative process, experts with lived and living experience, can use our data to try and improve the lives of people living with brain injury who are both housed and unhoused. So let's get into it. Start with a little bit of background. I'm obviously preaching to the choir here, but traumatic brain injury, or TBI, is broadly defined as an alteration in brain function that's caused by an external force. Homelessness is broadly defined as lacking stable, safe, permanent, and appropriate housing. And similarly, precarious housing is when you have shelter, but shelter that does not meet core housing needs. And so there's a huge amount of health challenges facing people living in homelessness, from simple things like lack of phone or internet connection to schedule and be followed up with for appointments, to not having an address to get mail, or to not having an address to make it through the bureaucratic process to apply for benefits and so on. But when we started this work, there was really relatively little that was known about brain injury in vulnerable populations, such as those living in homelessness. And so I'm going to walk you through just a simple series of questions. That was our thinking that evolved over time, and then I'm really looking forward to hearing what everybody thinks and where we should go in the future. So when I started with this, my very first question was, how many people living in homelessness have experienced a brain injury? And this is, of course, the number that's been thrown around all day, but I'll walk you through the sort of behind the scenes here. So this is what's called a systematic review and meta-analysis, where we as experts, we look at every single study in the field that's been done on this topic. And there's power in numbers. So we can tell more about a topic on aggregate than we can tell from any individual study alone. So we collected data from 38 different studies that have all looked at how many people living in homelessness have a history of traumatic brain injury. And we found very broadly that when we look at any sort of TBI, any severity, we find that more than half of all people living in homelessness have a history of traumatic brain injury. This is the one that made the news, and this is the one that ends up as the sort of stat. But what I find more striking is that when we look by severity, so if we look at moderate and severe TBIs, we find that more than 1 in 5 actually have a history of moderate and severe TBI. So to try and put that into perspective, I spent hours on a plane home a few weeks ago putting all of these little bubbles in a line. The top row of bubbles is the proportion of people that have a history of TBI in the general population, give or take 12%, although the research is sort of all over the place. And then more than 50% in a homeless sample. That gives a rate that's about 4 times higher. Again, more striking is when we're looking at moderate and severe TBI. The rates compared to the general population are actually more than 10 times higher than what we would expect to see in the general population for these clinically very significant brain injuries. Now, this is prevalence, so this is looking back in time. What's also really important, especially epidemiologically, is incidence. So this is when we take a group of people and we follow them for a period of time, and we want to know how many people would sustain a TBI in, say, a year, for example. And I have the labels here, some studies and other studies, which is wonderfully unscientific, but some studies found that if you followed a set of homeless people for a year, about 0.5 would sustain a brain injury. Other studies, the bottom row, found that that number might be actually 30% per year. So to me, looking at this, I can't make any firm conclusions because it's all over the place. But this ranges from important for the people that get brain injuries in the 0.5% to a huge public health concern if it's 30%. And so I tease this because we will show you what we found later on. I also tease this. This is not meant to be read, of course, but we synthesized every other finding, so related to health and functioning. So we found that TBI is strongly associated with poorer mental and physical health, higher suicidality and suicide risk, poorer cognitive functioning, as well as higher health service use and criminal justice system involvement. These were the ones that were really strongly related, and I think this probably rings true to many people. But there was also all of these other different things. And we were really left with more questions than answers. The literature, the scientific literature that has been produced on this topic has been relatively weak. And so some of the questions that we were left with were, for example, how many people living in homelessness sustain a TBI during a given year? When do they experience a brain injury relative to when they become homeless? And how is brain injury generally related to health in this population? And these were questions that we couldn't answer at the time, and so this brings me to the hotel study. So the hotel study is a longitudinal study that has been running since 2008 out of the downtown east side neighborhood of Vancouver, BC. So here we have a heat map of admissions to the local hospital for neurologic diseases. This is a heat map for psychiatric disorders, and this is a heat map for substance use related problems. And you can see the downtown east side neighborhood highlighted in the red circle. So this is a neighborhood with a high prevalence of homelessness, high prevalence of precarious housing, and overall a high burden of mental and physical illness among those living there. So we have recruited more than 500 participants, and we give them monthly and yearly assessments of health and functioning. So it looks something like this. Over a given year, we start by giving them a series of brain scans. We give them a comprehensive test battery on a whole range of health and functioning items. They're eligible, if they would like, to come in every single month for an additional sort of subset battery. And then at the yearly follow-up, we will give them another brain scan. We will give them another set of tests. And this goes on for as long as we have funding and as long as they are interested in coming back. And so the real power of this has been the longitudinal component and be able to see how things change and evolve over time. So I'm not going to go into this at all, besides saying that the dashed gray line that goes from 0 exponentially up is data that we have that is showing quantitatively the start of the drug poisoning crisis. Since it's been going on since 2008, we just are able to look at it in this longitudinal way, which is important scientifically, it's important for policy, but it's also important for people on the ground working in the community. So I am coming at this, as I said, brain imaging guy, I'm a data guy. I've always been focused in traumatic brain injury, and I joined the study because the study was looking specifically at traumatic brain injury. So starting in 2019, we focused on TBI in this study, where we structured it such that we would assess hotel participants for a TBI every single month with a really detailed assessment. And then if they got a TBI, we would give them a whole battery of extra assessments, including extra brain scans. We would also take somebody that was very similar to them in the study, and we would test them too. It's what's called a control. And so now we have this setup where we can see how things change and evolve over time, especially before and after TBI. So now with this, we have more questions and we have more data that we can actually answer these questions with. So first, within the hotel study, we wanted to know how many participants experienced a TBI and how did they happen. And I got to preface this with the 1 and 2 number, the 50% number. That's what got caught up in all of the news. That is really limited by the previous studies that have been so-so. We, through a really detailed assessment at this, we talked to every single person in detail about their entire history of TBI and their lifespan. And what we found that was in the hotel study, more than 80% actually had a history of TBI. In the general population, you would expect motor vehicle accidents, sports, that sort of thing to cause TBI. The most common mechanism, so this is looking at mechanism of injury in the hotel study sample, was assault, followed by falls. And you heard last year about the role of intimate partner violence, which you could see in the inset here when we look by just simple sex differences here. Females are significantly more likely to receive TBI through physical abuse than males. So a next question for us is, okay, well, how is TBI actually related to housing loss? So this figure is complicated, and I'm going to walk you through it, and then I'm going to tell you what the answer is. On the dashed line going down to 0, that is when we look in the entire housing history of our study, that's when they first became homeless. Any data on the left-hand side of that is they received their TBI before they became homeless, and then any data on the right-hand side is TBI after they became homeless. And the blue bar is mild TBI, the red bar is moderate and severe TBI. What this means is that more severe TBI is very closely linked with initially becoming unstably housed, whether that's homeless or precariously housed. So that's an important severity effect. There's also sort of a timing effect where people that had TBI very close to losing that initial stable housing were homeless for longer after that and had more challenges getting out and back into stable housing. So I think this was an initial attempt to try and highlight the role of different injury-related factors. As we've said earlier, every TBI is different, but different injury-related factors in the experience of homelessness and unstable housing. So I'm a brain imager, so I can't help but throw in some brain imaging, or I guess some more for you at this point. Our question when I started with the study is, if we look through all of these scans, how many people would we say that person has had a brain injury? There's like a visible, what we would call a lesion or brain bruise on a scan. That is a super high bar to get to. And what we found was that a whole 7% of our hotel study participants had some evidence of a previous TBI. And when we look at where these lesions occurred, so this is just a side-facing brain, the yellow and orange colors indicate there's more brain injuries in a given region. All of these brain injuries are affecting the frontal and temporal lobes for the most part. And so these, of course, are brain regions that are integral in decision-making, emotional expression, and impulsivity, which, as we know, can often be impaired after TBI. I teased it earlier, but we want to look at incident TBI, because this is an important public health piece of data. So next question is, how many people living in homelessness experience TBI per year? So what we did was we have all of these detailed assessments. We follow people month over month. So after a whole entire year, we've got a set of data that we can say, okay, we've followed a homeless and precariously housed sample for a whole year, and we can see how many had TBI. And that number is about 30%, which I have a hard time contextualizing this, partly because a lot of the research has been not very good, partially because it's challenging to compare to any other rates of TBI. This is higher than NFL football. This is higher than active military service members. And 12% of our participants with a high sort of granularity of data received multiple of these TBIs in a given year. So again, I'm sort of preaching to the choir here. I know that you know that this is important, but it's important to have the data to back up what we know. I have worked on front lines with our study. I have worked on the front lines in overdose prevention sites, responding to overdoses, administering Narcan to people, seeing the effects of anoxic brain injuries, and so on. But we need to show that the data supports what we know on the ground. And so this is just a very simple question here of using brain imaging, indulge me, are there very immediate brain changes after just one mild TBI? This is if I wiped out off my bike, and every other recovering young male in here feels me on this. I sent it down something, hit my head, pop back up, I feel woozy, but on we go. This is that level of brain injury. You can probably imagine there are widespread what we call microstructural changes after just a single mild, otherwise innocuous seeming brain injury. So I'll walk you through the figure. On the left-hand panel is our control group. So these are people that are living in homelessness, have substance use and mental health concerns, but they did not receive a TBI. On the right-hand side is the change in the TBI group, and this is looking at just a few slices going down the brain like this. And all that red and orange is the brain regions in the sort of white matter, so it's like the connecting fibers of your brain that were disrupted with just what otherwise seems like an innocuous mild TBI. So again, I think it's really important to show that there's just single mild TBIs have a measurable effect on the brain, and this is in the context of everything else going on with substance use, homelessness, and other health concerns. So there's also a similar question, is are there long-term consequences to TBI? And how important actually is TBI in the context of what else is going on? And so we looked at TBI in the mix with all of the other sort of risk factors that we wanted to look at with the hotel study sample. So this included mental health, neurological health diagnoses, as well as substance use, IV drug use, viral illness, cardiovascular risk factors. So these are what you would see in sort of dementia, as well as history of TBI. And this is from a study overly complicated study that we're getting ready to submit here, but it is ultimately relatively straightforward. On the x-axis, we have the age of the participant. So you go along the x-axis, they're getting older. On the y-axis, we have whole brain tissue to intracranial volume ratio, which is an unnecessarily but technically correct, or unnecessarily complicated but technically correct way of saying the amount of brain tissue inside your skull. So what we would expect in the general population is as you get older, your brain atrophies. That is normal. And so we estimated that with a big data set in the dashed blue line. Every year, you have a little bit less brain tissue in your skull. The individual trajectory of each hotel study participant are the light gray lines, so you can see they vary. And then the average hotel study participant is plotted in orange. And so what we can see is very clearly around between age 40 and 50 or so, there's a similar trajectory in early years, and then there's a much steeper trajectory after about age 40 or 50. And one of the things that we think this represents is this idea of sort of cognitive reserve, or the brain and the body is able to withstand insults, and it's able to withstand getting sick and getting hurt, but only for a period of time. You have a buffer room, but eventually that buffer room runs out. And so that's what we think we're putting now quantitative brain data to, is you have resilience and you have the ability to overcome these TBIs and different factors at younger ages, but at a certain point, you lose this reserve, and then you have a more rapid decline in brain health and brain functioning. Now, one of the questions people love to ask neuroimaging people is, who cares? Which is a very fair question. So this is another thing that has stressed me out for my entire PhD. But actually, I guess before I go on to that, the things that you would expect: alcohol, cardiovascular risk, which are risk factors for dementia, and TBI are all accelerants. So they make that decline even faster. So for the who cares question, we looked at the relationship between these brain imaging metrics and change in cognitive functioning over time. We found that a more rapid rate of atrophy is associated with a much more rapid rate of cognitive decline. We also have focused in the last few years on the relationship with mortality. So we recruited initially about 500 participants, and when they were recruited, the average age was about 45 years old. The study's been going for 12 years or so. At this point, we've actually had 100 people die in our study, despite the average age only being 45 at the study outset. And so more brain atrophy is linked to TBI. TBI gives you more brain atrophy, and that more brain atrophy is strongly, strongly linked to mortality over time, independent of everything else that is going on within people living in homelessness. So here we have time in the study in years, and on the x-axis, and then on the y-axis we have what we call survival probability. So you start at 100% of people are alive, and every tick down is a death. I always find these figures particularly striking because every single tick here is some family's loss. What we can see in especially the red line is it ticks down very, very fast over time, and these are the people that have the highest burden of traumatic brain injury and the highest amount of brain atrophy. And so far I've been largely talking about traumatic brain injury, but as other people have alluded to, there are different types of brain injury. We've just begun to look into overdose. This is partially because we only had limited data. This is partially because we only have limited capacity to look at so many things sort of at once. But a brilliant master's student with our group has begun to ask questions supported by us, asking, is the risk of overdose, for example, increased after a TBI? We're all familiar with the toxic drug crisis, but what is the link of TBI in this? And so the first thing that she found actually was everybody reports their substance use to us, and people appear to self-medicate with opioids after a TBI in our study. And so the frequency of opioid use after a brain injury is increased in the people in our study. The other thing that we have found is we can't really account for the people that die from overdose in our study, but we can track the people that receive naloxone. So they overdose, but it's not fatal. And so what we have here is the time after TBI on the x-axis, and we've got the percentage of our study sample that has received naloxone for an overdose on the y-axis. And so as these lines tick up, that is representing more and more people that are needing naloxone after an overdose. In the blue is the control sample, so those that have not ever received a TBI, and in the red is those that have received a TBI during the study period. And so this is strong data to suggest that the risk of a non-fatal overdose is actually twice as high after a TBI compared to not having a TBI. So this is, again, first time anybody has seen this. Please take this data and share with people that you are able to. And so the media and people asking questions and the policymakers, they always want the silver bullet. What is the answer here? And I always have the distinguished challenge of standing up here, and again, I'm preaching to the choir, but saying that there are no silver bullet solutions here. What it looks like from our perspective is this. Housing instability is a core piece, and it is a huge risk factor for sustaining brain injury. On the flip side, we've also done the same work in the opposite direction. So brain injury is a huge risk factor for housing instability. And so, of course, there are other health challenges, cognitive impairment, substance use, non-injury, non-health related factors. There's different types of brain injury, from traumatic to anoxic to other acquired brain injury to intimate partner violence. It's complicated. But the core piece to us seems to be this cycle of housing instability leading to brain injury and brain injury leading to housing instability. And so while this seems like a vicious circle, and as I said earlier, I worked in an overdose prevention site. I've responded to dozens and dozens of overdoses. I have seen participants in our study with TBI, with overdose, go down this cyclical path, and many of our participants have died. But there's also two key areas for intervention in a cycle like this. So first is housing instability. This was, we've provided data that this is an important piece. So in theory, if you provided stable housing, you would be able to reduce TBIs. And we haven't been able to do that. We are clinical researchers. We don't have the ability to provide stable housing. But researchers and collaborators out of the University of Toronto have given us this data, and it's phenomenal. So I'm just giving it away in the title here. Stable housing prevents TBI. The addendum to that, or the more detail to that, is this is part of the what we call the at-home chez soi study. It's run by people out of the University of Toronto. It's a massive study that was a randomized controlled trial looking at rent supplements. So this is where we take a group of people, we give half of them rent supplements, and we don't give half of them rent supplements. And we see what the effect of rent supplements are. And these RCTs are effectively the gold standard of a scientific study that allows us to say, this causes this, and that's the strongest data that then we can try and move into practice. And so they did this. There's a variety of benefits to it, but one study that they put out in the last few years looked specifically at traumatic brain injury. And they found indeed that with stable housing, there is significantly fewer, especially violent-related TBIs in those that receive rent supplements compared to those that don't. So this is early data, but data to us that suggests indeed TBI is able to prevent, housing stability is able to prevent TBI. On the flip side is the brain injury side. Now, to me, there's sort of two sides here as well. There's prevention and there's treatment. And I always feel self-conscious up here because I think most of you in the room know better than me. You're policymakers, you're people with lived experience. I push numbers around a screen and look at brain scans, which I love, but you know this better than me. So all I will say is that from our perspective, there is an avenue for prevention. There is fall prevention in the single room occupancy hotels and shelters that can absolutely be improved. There is like fall risk at overdose prevention sites that I witnessed. There's a huge piece for advocacy and education in the community as well. The other side to this is also the support and treatment, of course, but one thing is screening. So basically nowhere that we have looked at has had TBI as an important intake piece on their initial paperwork for shelters and that sort of thing. And so that's one thing that we think is particularly important. I have one small anecdote to share with you off script. One of the reasons that the study has been successful is because of their research assistants. They live and work in the downtown east side. They are so proactive. They know the participants. They are just phenomenal. And I think it provides at least some amount of a perspective on what we can do for improving treatment and follow-up in this sort of community. So there's one guy named Jim, I changed his name. He, as similar to the brain injury I saw on the initial screen, TBI, a lot of memory impairments. And so he has all of these problems with missing his appointments. His healthcare is worse because he misses appointments. He can't be tracked down, has all of these challenges. One of the happiest guys that I've ever met. But it's amazing to see our research team work, where on the day that he has an appointment, they call him up 8:30 in the morning, and they say, hey, Jim, you've got an appointment at 2 o'clock. And he's like, oh, sounds good, I got it on my calendar. And then they call at noon, and they say, hey, Jim, you've got an appointment at 2 o'clock. And he's like, oh, I completely forgot. I've written it down. Got it in my calendar, no problem. And then they call at 1 o'clock. They say, hey, Jim, so on and so forth, to the point where they're calling him at 2:30 for a 2 p.m. appointment. And he's like, well, I left the house, but I bought a pack of cigarettes, but honestly, I can't remember what I was going out for. And they're like, well, you're going out for the appointment. Do you want to, we'll send somebody out. Where are you? We'll send somebody out, and we'll come meet you and bring you in. And that has been integral to the success of this study, but I think also highlights how much work sometimes there needs to be going in to provide help to these people. So the Jim comes in, we give him a small stipend for participating. He helps us out, chats with everybody. We fix some prescription issues for him, and he's sort of better than he was when he came in. But I think it was 4 phone calls by the time that had happened. So looking forward, I'm on the science side. There's 2 things here. We got a grant a year or 2 ago that allows us to continue our work for 5 more years. We do not have stable funding, so if anybody ever wants to come and work with us, if you have questions, if you have suggestions, I've got my contact on the last slide. Let us know. We're keen to work with anybody and everybody. And if anybody has connections to funders, we are keen to hear from you. Can I get my slides back up, please? There we go. The second piece is the sort of behind-the-scenes scientific advances. So this is one thing that I did while in Boston, and I'll just tell you, try and convey in 1 minute why you should be excited about something that's really hard to understand. We were looking at therapeutic targets for addiction and substance use disorder. When you look at the whole entire scientific literature in one slide, these are different brain slices. Every red dot is where a study has said you should target here or here, right? So once again, you don't need to be a radiologist or a scientist to be like, well, where are we supposed to target our new therapy, right? This doesn't make any sense. But there are some new and emerging techniques, one of which I worked on with the group in Boston. I know this just appears like a bunch of orange and blue blobs. I'm well aware of that, but trust me when I say the bottom panel makes the top panel all make sense. The most blue areas and the most orange areas are where you should absolutely target a clinical trial for neurostimulation to treat substance use disorder. It's sensitive, it's specific, it uses causal data. I will happily talk your ear off after if anybody wants to know. But these are now being used, MIT, Harvard, their groups, to do clinical trials on these regions to target substance use disorder. Also anxiety disorders, also depressive mood disorders, also Parkinson's. There are new and exciting scientific advancements that are going to be able to help things that are related to TBI. One of the things that I learned over my time as a trainee is how bad scientists are at letting anybody know what they found. And it's shocking. It's the ivory tower. You tippy-tap away on your computer, you get the grant, you write the paper, you get the grant, you write the paper, and that's it. And so one of the things that I tried to spearhead with another graduate student in our group was knowledge translation, which sounds basic. Again, to a group like this, I'm preaching to the choir. But one of the things that we did was start up a community brain art initiative. So this was working with members of the community as well as clinicians to make basic infographics of health of people living in homelessness, what you should look out, what are red flag signs that you should look out for? What should you be aware of in TBI? What should you be aware of in epilepsy? We also hosted art sessions with community members, which was super cool. Similar to this, but with members of the downtown Eastside community. provided endless art supplies and food, and you can imagine how many people came out for endless art supplies and food. And we said, what do you want to hear from us? And here's some things that we've learned that we think you should know. And that has helped to guide some of our research priorities. And again, I'm looking forward to hearing what you have to think for our research priorities as well here. We also commissioned other things. So this is a brain health and brain injury inspired mural. One of the other things that we've had is quite a lot of media exposure. Also an interesting experience. Usually the perception of homeless people in the media is stigmatizing and mean. So we actually try to avoid it sometimes. In this context, I was floored. The idea that many of the challenges that these people face could be in part due to a brain injury led to this massive outpouring of support and understanding, which I thought it blew me away. And so again, the education and advocacy piece that is generated here has a measurable effect of improving stigma reduction and improving health for these people in the community. Dr. Thalia Field's a brilliant neurologist in stroke at Vancouver General. She and a former MD PhD student have been working very hard on a neurology outreach clinic. So once again, we had a discussion at our table about sort of bureaucratic red tape. There is no MSP billing code for a neurologist to do a house call. So there's no incentive for neurologists to track people down. And this is ignoring, obviously, how overburdened neurologists and our healthcare system is. And so these two go in pro bono, and they're like, what do you need help with? Do you have Parkinson's? Are you on your medication? Have you had a TBI? Do you need support with services? Do you have epilepsy? Are you taking your medication? And a very proactive approach to neurologic care for this population in the downtown east side. And finally, there are, of course, practice and policy improvements that can be made. This is a paper that was out very recently, again, from collaborators at the University of Toronto, that looked at traumatic brain injury practice guidelines and found that essentially none mention any sort of housing instability or homelessness as a key factor. I can tell you from the homelessness side, there's essentially no clinical practice guidelines that recognize TBI as an important factor. So there's people working on this. There's also, of course, practice and policy level changes that are going to come from groups like this and people in this room. And I have been so impressed and really encouraged at the determination of people in this room and the ability to get things done. And so my real hope here is that our work and the work of other clinicians and scientists is able to give you data that supports what you need in order to improve the lives of people with brain injury. So if there's 3 things that I want to distill down for you to take away from this talk, I realize I get excited and throw a lot of data, and I will confess that I stripped like 90% of the data out of this talk. The takeaway number 1 is at least, I would say it's far more, but at least 50% of people living in homelessness have a history of traumatic brain injury. Simple takeaway number 2 is that brain injury, we've shown, is a super key determinant of brain health, general health, mortality, and functioning in people living in homelessness. And simple takeaway number 3 is that housing instability is both a risk factor and consequence of brain injury. And so with that, I am up here presenting today on behalf of a huge study team. The PIs are Drs. Will Panenka, Bill Honer, and Al Thornton. This is a QR code for those of you, if you are so inclined. That's a link to our review paper. If you're not inclined to read a dense scientific paper, just Google us. There's other things that you can find. It's easy to find our contact info. Our emails are also there. As I said, the research team's phenomenal. Thanks to them, the funders for funding the study, and the participants who continue to come in and help us generate this data as well. As I also said, let me know, let Will know. His email's right there. Always happy to work with people. We want to hear what you have to think. And we're keen to work with people on whatever they think the priorities are. And with that, I will leave us with this slide. Looking forward to hearing what you think, and thank you for your time. You want to stay up here? Or get on?
Comfy seat.
Oh, sure.
And there are microphones there. While I get things shifted around, people can take photo of the QR code and get all organized. Jacob, this is yours. I did have someone ask me if there was any way to access your slides from today. Okay, so Jacob will be making his slides available. Not sure how that will look yet, but we'll let you know. Ta-da! So the questions also do come up on your screen in front of you. Let me just make sure. This is the first and highest ranked question here. So how can we shift from either none at all or best short-term or transitional housing to lifelong housing for people with TBI? You have a microphone. You just have to turn it on, I think. Yeah, it's live.
I think we're okay. This is where I need to tactfully deflect because I am not at all the expert on housing. I can try and find the best person for you to talk to. Talk to me afterwards. We do the data behind the scenes. I am not a policy person, and I cannot give you a good enough answer to take up any other time.
All right. So next question. So is there any changes in TBI incidences when study participants are able to access safe supply?
Brilliant question. We don't have that data, but anecdotally, I would say absolutely yes. As I said, I worked at a overdose prevention site. We were affiliated with a safe supply program, and the people that were on the safe supply program were so much more likely to be stable in every other aspect of their life. So again, no data, but anecdotally, absolutely yes.
How can we help support folks maintain their brain health if they are unhoused?
As we've mentioned, every brain injury is different, and I think this comes down to an individualized approach, which again, is a little bit of an unsatisfying answer, and I hear that unsatisfying answer. But for example, like our study team knows specific people that need to be tracked down in a specific place to get their medication. This is like a proactive, coordinated approach to healthcare. Again, this is now getting beyond my level of expertise, but I would suspect if we are able to have a more coordinated, assertive, proactive approach, I would argue through team-based healthcare, that is how we have the best shot at improving brain health. The other thing that I can say based on our data is that intervening in younger years is key to preventing decline later in life. Not to say ignore the old people, of course, but different people have different needs, and recognizing that can help tailor care and improve brain health to both younger participants and older participants.
I'm just going to jump ahead here for a second. So are you aware of how TBI and homelessness in Canada compares to other countries across the world? Are their rates similar or not tracked?
Super good question. The literature, as I said, is an absolute mess. So I can't give you a good answer because there is not a good answer to be had. Again, unsatisfying, but that's it.
Next one. How can we shift from either none at all or best short-term or transitional housing to, I think we've asked this one, haven't we?
Already dodged.
Yeah, sorry.
I apologize.
Is there a change study participant? Yep, sorry. How can we help support folks maintain their brain health if they are unhoused?
Did I answer that one already? Proactive, comprehensive, team-based.
Okay, let's go. Which is more expensive for society, providing housing or dealing with people with a TBI?
I'm not a politician.
So that gives you permission to answer
I'm not
any way
sure
you
why
want.
we need the tee up here. I think very clearly providing housing is providing housing, but also I want to emphasize that from our perspective, there are no silver bullets. Providing housing does not solve this problem. It is providing housing It is addressing the drug toxicity crisis. It is addressing the health problems related to TBI. It's addressing all of these in a comprehensive way that will move things forward.
Is there a study on how many people were using substances before their head injury versus how many use substances after?
There is no study because we have not published it yet. It is data that we have looked at. There's no big changes in what people use. There are changes in how much people use. And so this is data that I showed you one slide of among a bunch of other fancy and colorful slides. But people who use opioids use significantly more opioids after a TBI in our study compared to those that don't get a TBI. And so again, whether this is medicating their symptoms, whether this is some other reason for an increased use like impulsivity or lack of control related to a brain injury leading to more consumption, we don't know the answer to that. What we do know is that people definitely use more opioids after a TBI.
How many participants have died due to the toxic drug crisis since the start of your study?
We could find the answer to that. It's hard to answer that question specifically, though, even if we Google the classic blue Excel chart. Oh, sorry, how many study participants have died? My bad. 100 participants have died. We think it's about 1/3 to 40% have been due to drug toxicity, which I'm not sure whether that strikes you as low or whether it strikes you as high. Again, this is a really young study sample. Average age was 45 when they studied. So yes, there's a lot of overdoses, but there are a lot of deaths and what we'd call comorbidities due to what appear to be age-related problems. Like memory impairment in the general population is not a concern unless you have mild cognitive impairment as a precursor to Alzheimer's disease when you're in your 80th year. These people are experiencing this in their 40th year, in their 50th year. And so there are a lot of deaths that are complicated in the study. There's a variety of reasons. But to answer the question, about 1/3. The rest, though, are not straightforward either.
Okay. Let's just do a couple more. Do you have the stamina? A couple more questions?
We have 42 on the docket here.
We're not going to do all of them. How do these brains compare? And how do these brains compare to a scan of severe mental illness or severe substance use?
This group has such good questions. So you could, whoever answered this should do a PhD. I should probably, yeah. It's complicated. There are no diagnostic brain scans that can show mental illness or substance use. That's like when we look at it in a clinic, we think of like we need a diagnostic scan, right? We need to put a single person in a scanner and get a result that shows this person has a brain injury or this person has schizophrenia. That doesn't exist for something like schizophrenia. And so the research is ongoing, but it's an area of active research that I am not very optimistic will come to fruition anytime in the next 10 or 15 years.
Okay. So we'll do two more. Sure. Two more questions. Could your researchers partner with university communications students to find a more effective way to share data and address stigma with the wider population?
That's a super good idea. We've historically in the study, there have been some older researchers that I will not name who have not thought knowledge translation is worthwhile at all. So it's a new concept that we're trying to integrate into our whole research group. We've done sort of a policy level approach, met with the mayor, met with people in government. We've done some media. We've done our brain outreach project, but I think that's certainly a great idea to take experts in communication and experts in this topic and merge the two.
Great. Okay. Last question. Oh, what does death from brain atrophy look like?
It's almost philosophical to end it. Death from brain atrophy itself doesn't look like anything besides a brain that's shrunken down, but it looks like all of the clinical, and for lack of a better term, functional manifestations or phenotypes. A better way to say that is what your loved one looks like when they're going through dementia or something. It's a slow, progressive, complicated decline in functioning, in who that person is, in what that person is able to do. So similar to traumatic brain injury, general brain decline is varied from person to person.
Thank you so much.
Thank you, and thank you to everybody in this room. This has been a spectacular few days.
Before you run away, we have a little gift for you. Okay. I'm going to turn things back over to Maurizio to walk us through some closing comments and provide us with some reflections on the work that's been done so far. Oops, sorry, do you want that yet?
So good to see the stats with the learning that has occurred in this room. I can see that we are starting to get ready to go out to enjoy the summer days. I will be brief with some of these closing comments. I just wanted to share with you a little bit the outcomes of the last 2 years of work and trying to integrate a little bit with what we have learned today. So this is initially the expected outcomes that I talked about at the beginning of today's conference. This is what we are starting to find. So there have been some themes that are emerging, and of course housing, as we learned this morning and throughout the day, is #1 theme, hence what we're doing these years. But I also want to point out that we are doing some papers and some explorations of the data that are a little bit deeper analysis of what we are discussing in every one of those tables in the room. So for year one of our brilliant students, Jasleen Gruwal, here, which, by the way, thank you so much for taking notes today, Jasleen. She's a student from UBC, from Dr. Julia Schmidt's lab, and she is in the process of publishing a paper that is undergoing review called Understanding the Barriers and Facilitators of Brain Injury Healthcare Services, a qualitative study. So it's not out yet, it's in the review process, but one of the important features of the article is that it identifies 3 categories. One is this invitation from all the tables that were in that first meeting, the conversations on those tables, of thinking about acquired brain injury in its complexity. And we have heard that so much again and again. Yesterday, today, we hear about that when you meet, I think that was Heidi or somebody in the panel, when you meet one case of brain injury, you have met one case of brain injury. Every single case is so unique. So it's in part associated with this complexity, especially when we talk about the intersections. Also, this complexity needs to be brought up to the attention of the public for the awareness, because we cannot create like one solution fits all. And from the presentation from Dr. Stubbs, Jacob Stubbs, and from many other conversations today, we have learned of this as well, that that's one of the challenges of this kind of research. We just cannot come up with one solution, with a silver bullet. One of the things that we learned as well is that, and Heidi, Wendy, you actually talk about this, is that just providing housing, just having a roof is not the solution either. You know, it's part of it. We will all agree, I think, we all will agree, but it's not as simple as just that, having a door and a key. It's required to have solutions, services, systems in place to support inhabiting this place and having the opportunity to overcome the aftermath of brain injury. The second thing was the need to enhance existing supports, including healthcare, both professional and community-based supports. So lots of injection of funding, education, because there are systems in place. Right here in the room, we have lots of representatives of those systems in place, organizations, associations, brain injury societies, but we need more funding to outsource them. We also have, in another theme, changes to the structure of care, need to create pathways to care, eliminated systemic barriers. And we talked today extensively about the need to have that one entry point that congregates all the services into one place, and system navigators that facilitate receiving all the services that are needed. So it was very nice to see from Jasleen Gruwal the analysis, the qualitative data analysis, that these themes are emerging consistently. This was based on year one. One other outcome that we are expecting to produce is this articulation of a research mandate. So it's all of you all together throughout the 3 years of work telling us as researchers, what do we need to do next? So this is really good for researchers like ourselves, because when we apply for a grant, then we are telling the grant agencies, the funding, this is not just us coming up with these questions or with these needs to do research. This is coming from a congregation of community members, stakeholders of all kind of representations, healthcare practitioners, people with lived and lived experiences of brain injury, and all of you telling us these are the priorities for research. So my student called Kennedy, it's in the midst of having this published. We should have it published within a couple of weeks in the journal Health Expectations. And the title of this paper is 10 Priorities for Research Addressing the Intersections of Brain Injury, Mental Health, and Addictions, a stakeholder-driven priority setting study. So what does it mean? Is simply the whole process that we took during the year 1 of ranking the priority questions for research. And the top 3 out of 10 are, what are the experiences of concurrent brain injury, mental health, and addiction for homeless or marginally housed people? And how do their experiences differ from people who have stable housing? We can see that the hotel study that Dr. Jacob Stubbs introduced us to has already started to address some of those questions. And there is so much more to do in that regard. Second question was, what is the incidence and prevalence of non-fatal opioid overdose related to hypoxic and anoxic brain injury? And how do we best identify and support people who suffer this type of brain injury? So a lot around what are the resources? What do we need to do? But based on what is the incidence? How big is the size of this issue that we're dealing with? So it's a call to implement surveillance systems. And I think that, as you heard this morning in the opening remarks from the ministry, from Dr. Vigo, we want to pay attention to those numbers. Something that I keep reflecting when we emphasize the area of surveillance and numbers is this invitation, and I think that, Jacob, you also remind us of this, that behind each one of those numbers, there is a whole history. The film about Heather, the stories that we have heard in our panels during these three last years of these conversations really help us to identify those unique stories. And they're not just the numbers. Shirley and Jacob's story that we have learned and benefited so much from, those are unique stories. Not just a number being part of a big pyramid of numbers. However, those numbers are the ones that allows us to really showcase the breadth and the depth of the issue. It's what allows us to bring funding and bring governors and all kinds of representatives to the room to discuss these issues. What are the specific long-term cognitive consequences of non-fatal opioid overdose-related hypoxic and anoxic brain injury? For instance, are there problems with attention, memory, communication, executive functions, etc.? This is a big part of the work that we want to move forward to do. As a group of researchers in neuropsychology and occupational therapy, this is a big question for us. So we really thank you for bringing this forward, because now we have a mandate that we can bring down to the funding agencies and say, we need to look at this. We need to do assessments. From year 2, very similar outcomes. I won't read each one of those, but they are in the report that is available in our Brain Consensus website, BC Consensus Brain Injury website. So the top 3 are identify and explode the system gaps. Expose, I think that is what it wants to say there. So super important to really that discussion around when we talk about brain injury and the context of intimate partner violence, to expose the gaps. What are the places where people are falling through? So that's a mandate that came out. Track long-term impacts. This is very important in the conversations around Bill C-277. We have really emphasized that part, and it is the long-term denomination of brain injury. We are very good at addressing the acute phase of brain injury. If we manage to get somebody to the ER, there is very expertise care at the ER level, but then you get sent home and good luck. And if you have strong advocates, maybe you get a lot of other resources, but they end quite prematurely in many cases. So really working in the long term. And also evaluation of the effectiveness and prevention of intervention strategies. That's a big. So in my lab, Cole Kennedy is leading a big project called it's an evidence map project, decision map, and it's a synthesis type which compiles visually all the evidence that exists since 2015 around interventions for brain injury and all the indicators if they work or not regarding a number of different outcomes. When that is available out there published, we'll circulate it through our networks, through the communications that we use to get in touch with all of you, and in the website for this project, because we want everyone here to benefit from having access to that information. It's a very easy tool to navigate. And there are many more mandates there. Now, other outcomes, and Jacob, you also mentioned this. I was very pleased to see this. We tend to be in academia very mindful of like publications and grant funding and the dollars associated with that. And yes, we're measuring on those outcomes. But more and more, especially in community engaged research like this one, we are committing to translating this knowledge into everyone that is willing to listen. You know, everyone from the media, from radio, politicians, but also caregivers, family members, everyone that doesn't have the scientific training. So big part of this outcome section is related to that. So for instance, BLC 277 campaigns are big campaigns to create awareness that every case is different. Every person in that 167 days to say, and now we have, yes, 125 days to say yes. It's different and it's unique and has a different story, and they tell us the story. So that's super important for awareness and to diminish stigma. We have lots of social media postings, Instagram, Twitter, everything that we can get our hands on. We share and socialize around this. We also have conducted lots of radio and TV interviews. Janelle's a star in the media, and it's very good to be able to talk about these things with everyone willing to listen, especially because sometimes the media can take pieces from here and there and sort of like give them their own angle, you know, because it means clicks and attention. But when we are there speaking, then we are the voice. And if we're representing your voices, that's a great way to generate knowledge. So these are significant outcomes. We have been in many, many of these interviews. We have also the publicly available reports. So we have those in the website that you can access if you want the nitty-gritty of everything that happened in this room during our 3 years. We have lots of other different outcomes. One that I want to bring to your attention is this piece that we just published on Sunday on the Conversation Canada. The QR there takes you right away to the article. It's a short article, 2 pages or so, but it kind of like pulls together the issue of the crisis that we're observing around the non-fatal drug poisoning events. You know, all of these cases of people who have survived, which is really good, an overdose, but they are left without any servicing, without any supports. And we are kind of like documenting and being a little bit critical of the need that we have to really talk about that significant number of people beyond the counts of those that have not survived an overdose. So that piece really gets to the point of that. I recommend it. And it has lots of links to data and places. We also have done many conference presentations, locally, nationally, internationally, trying to bring the message from BC. As Danielle reminded us this morning, and Minister Whiteside, we are really at the leading edge of this kind of research. And they really want us talking about this because they want to use it as a template. So feel very proud that each one of you is contributing to the building of that template that will be used in several places across Canada and beyond. And finally, we are committed to continuing this research. It's the end of it, it's the end of the road. We're in the 3rd year, but we are not done. You know, this is, if anything, the beginning. Also similar to Jacob, you pose a lot of questions that the research is bringing up. Similarly, our outcomes are going to look like a list of questions. So as we evolve in this following year, taking together year 1, 2, and 3, we'll come up with lots of questions from your mandates of what needs to be researched on, but also from all the processing all the data we have gathered in 3 years. So we'll have more questions to address, and that needs funding. So we'll be knocking at several of your doors to create alliances, collaborations, to have people that are here in the room that understand what we're talking about be part of those requests for funding, because we need all voices integrated. So thank you so much for that. So this is back to the original slide. We have achieved quite a bit of those outcomes. We have not completed the whole picture. The one in the box with red are those two that is really our main focus for this year to come before we fully close. We don't have more meetings like this scheduled, but hopefully we have later on an opportunity to socialize broadly the outcomes. One of those is the development of a consensus statement. So this is like the true nature of like putting together 3 years of work into one statement that is synthetic, that is clear, that is effective in telling everyone willing to listen what is needed out of this research, what is needed to have an impact in our community. And the generations of guidelines. That's a big commitment that we have as clinicians and as researchers in this field, to have some guidelines that will be taken as recommendations, but under the umbrella of the national strategy, hopefully, they're more than just recommendation. Hopefully, there are true guidelines that are going to be used locally and nationally for the benefit of all of us. In ending, I have just 2 slides to end my remarks. We have calls to actions. So from year 1, we have talked a lot about this need for the creation of a hub approach of integrated care. We have examples that are being built, and we need more. We need more of these clinics that are able to service mental health, addiction issues, but also the brain injury in one place. We also have a call to action for the government in the provision of accessible, affordable, tailored housing options for people living with brain injury. So again, not just a roof, not just a key to a room, it's something where they can access services as well, and that are adapted for people that are dealing with the aftermath of brain injury. And also an improvement on the diagnosis and recognition of brain injury. And Dr. Stubbs as well today remind us that there are very limited tools to do screening. We need to improve that, to ask the simple questions at the door. Is there any suspicious of having experienced a brain injury? Do we have this as a question even? Because the moment we're able to answer that question, if the answer is yes, there could be a code, and through that code there is a system that we can activate. But if no one asks the question, and the person facing this a moment in their lives doesn't know that they need to give this information, it's not going to work for identification. And for year 2, we have similar, the call to action to improve the level of funding and resources, to improve the access to standardized brain injury care with this long-term approach, and also to provide integrated care. So in year 2, that came about again. So we are bringing all of this in the reports to the government, Minister Whiteside, and as you have heard, they're starting to act in some of these. It may feel just like a beginning, but at least it's a beginning. It's better than when we started. So we're in a very good place. There are a lot of people to thank, and in these closing remarks, and I don't remember in the schedule if anyone is speaking after me, but before I leave the microphone, I want to, and call if you come here and help me to distribute a few things. So I want to really give thanks to a number of people here that have helped us to make these 3 years run like a very well-oiled machine. People that in the front and in the background have been so important to making this 3-year process achieved. So I would like to start, of course, with our mother boat of all of this journey, Janelle. This is our... Just a thank you note from the researchers, leads in this program, because you really have been the inspiration, the force that have filled these rooms with all this energy, with this commitment to work. You're really calling to each one of us and all the politicians and make all of this happen. You know, it's so easy to do the work when we have that inspiration every single time. And you, if you know Janelle, you cannot say no to Janelle. And if you know Janelle and you don't answer one email, you get 5. So you really want to work with her and be on top, and it really gets you going, and it's the way that things get done. If anything I learned is how to do a project from beginning to end to completion, like really to do it, and it's that commitment that comes from her heart. And we also have a number of people that have really supported us. So Sheila, where are you? It's hiding. Oh. Sheila has been our facilitator of all of this. Let me give her a hug. great facilitator of all this meeting, making them run on time, making sure that everyone has everything you need on the tables, taking immense notes, making sure that everything is working, coordinating with so many components to make this run so beautifully. So thank you so much, Sheila. We also have, very quietly there, ignoring me, Lisa. Could you walk to her? Yeah. Oh. Lisa, as you have seen, quietly in that corner, when no one is looking, is an amazing graphic recorder. That's the name for what you do. And it is to really create these beautiful images that map conceptually, visually, everything. I have to give you a hug. Don't go too far. She captures visually so beautifully everything that happens in this room. So that makes the synthesis of our conversation so accessible. We can share it so easily in a website, in poster presentations, in conferences, because it really navigates you through the unfolding of these long days. We also have people in our front desk that have been so important to get everyone located, situated, all volunteer work, just showing up so earlier than anyone, and leaving the last when the room is completely empty to make sure that this also runs. So I will start with you, Caroline. You're also there. Caroline helps us with controlling all the Zoom process in the background, like making sure people are in breaking rooms when they need to and all of that. So quietly in that corner, she's doing all this work. Thank you so much. And as you come in, you will greeted by beautiful smiles. We have two people that are so in charge of, like, everyone is registered, everyone has the paperwork completed, and they are Tony and Kathy. So if you can come forward. Thank you, Cole, so much for helping me with that. Just a small token of appreciation, there are a lot of more people that every year supports us so much. Jason and his team in the back, thank you so much. Jason not only make sure that we have all the information in the screen that we need to look at, and also the Zoom systems, but also the recording, so we can revisit this and use it as very valuable data of everything that is happening here. We have also from the University of Victoria, Cole in that corner, making sure that internet and audio visuals and sound, all of that is also working well. So thank you so much, Cole. And am I missing? We have so many people that also work with us as the facilitators, the moderators in each one of the tables, and the people that were taking notes for each table. Thank you so much. You're all students. Yeah. They are all students, volunteers that range all the way from high school, like Josh, all the way to grad students. So thank you. Thank you so much for all that you do. I know that we are running out of time and we're getting tired, and Janelle wants to wrap us up with some words. So, the microphone is yours. Thank you so much, everyone.
Well, thank you for the flowers. And that was all of them. That was nothing to do with me. So I appreciate you acknowledging everybody. Thank you all. This is, an amazing day. And to know that now we are going to fly from the bird's nest and begin to write this statement is incredible to think that we are here, that this actually started 3 years ago. So just a couple of things. Bill C-277, we will be in touch on how you can get involved over the summer. I will be looking to have 500 submissions across the country to that health committee. It's super important. But I did want to say something, and it was Connie in her comments when she mentioned that federally they're responsible for Indigenous communities. And I want to say that is exactly how I got Alistair McGregor to pick up the torch and carry this. I did my homework before I went to see him. I knew about the jurisdictions in the province. I knew that they only had to meet, not only, but they had to meet a 9-point criteria to have healthcare dollars transferred to them. So I asked him that, and I knew what I was going to say when he said, "Oh, it's up to the provinces then." Because then I asked him, who is responsible for our veterans and our Indigenous communities? I knew the federal government was. And he said, oh, that's us. I said, yes. And they're in every community, every province, every territory, and you need to be the North Star and lead this. So that's exactly how I got to him. And I'm so grateful that he's carried the torch for us. But I also want to say that Chris from Cowichan Brain Injury Society, she's here. She was like right at my shoulder, right at the beginning of this. And Michelle McDonald, who's on Zoom with Brain Injury Canada. And then it's just built momentum. We've had more and more organizations, you know, from Nanaimo to Kelowna come forward and be a part of it. I do want to give a shout out to March of Dimes. We have a few of their clients here. And I want to tell you that these fellows have been stuffing the envelopes for me every week. I drop off like 150 letters for them and envelopes for 5 days. They stuff them and we get them to the mail. And I really appreciated you taking that on for me. Shauna Fenwick, who couldn't be here today, she had a family situation, but Shauna took all 5,000 envelopes for me and labeled them, so that took that off my hands. So it hasn't only been me. There's been an army behind us, and we're so grateful for that. I do want to say the government is listening, and proof is I want to acknowledge that Carolyn Davison has been here all 3 years, and you were at the Ministry of Mental Health and Addiction Overdose Prevention. And Carolyn tells me that when anything comes through on her desk or anybody's desk with our names on it, it gets read and distributed. So they are listening, and I thank you for being here every year, Carolyn, and taking those messages back. And of course, a special tribute to all of our families and survivors who have attended here today. But I definitely want to mention again the Henderson family, Wendy Neercombe, her family coming from the mainland and being part of this, and Shirley Wilson, who, if you've, I don't know where, oh, she's over there. So Shirley, who she will tell you, I stalked her until she got in touch with me, and she came to Ottawa with me, and we've become really great friends. But her story of losing her son is an important story, and I applaud you, Shirley, for being brave and allowing us to walk alongside you and champion this in his name, as it has been my husband's name. So legacy work for both of us, and Shirley and I are in sisters forever now. So there you go. Wendy, is Wendy still here? Wendy, our panelist? She left. I do want to acknowledge how moving it was to have Wendy here and all of our panelists for the amazing information they brought forward. And Jacob Stubbs, thank you so much. Lots of feedback on your work already, and people are excited to connect with you. And of course, Clint with your film. And, you know, we're so grateful to have you in this community now. And I think you've heard from a lot of people, you need to move here. We're not letting you go. We have lots of things for you to do. Of course, Sheila and Lisa, we just cannot do this without you. It's been amazing. Sheila has been our North Star to keep us all grounded in what we need to do and get it done. So thank you so much. And of course, to Julia and Erica and Cole and Mauricio, this wouldn't be here had they not believed in this project. I'd still be helicoptering over those trees, if that's a term. But thank you. And Jason and Stream of Consciousness, again, Jason's team has been doing this for 3 years with us, and he has invited us if anybody would like to come forward to the stage, and he's going to take a group photo so we can finish off our phase and leave the bird's nest with a group photo. So you don't have to do that, but I invite you, anybody who would like to come and join us at the stage, and Jason will get a photo. So thank you for coming today. Thank you for believing in us, and thank you for continuing the work. Thank you.